Propofol infusion syndrome is a rare, potentially fatal syndrome. It is associated with infusion of propofol at 4 mg per kg per hour for 48 hours or longer. It is associated with acute refractory bradycardia leading to asystole in the presence of one or more of the following: metabolic acidosis, base deficit more than 10 millimole per liter, rhabdomyolysis, hyperlipidemia, and enlarged or fatty liver. The first reported case of this syndrome occurred in 1990 in a 3-year-old child in Denmark. 2 years later, a case series was published in the British Medical Journal describing similar presentation in 5 young children. A United States Food and Drug Administration study that year failed to find a link between the propofol and the further deaths, but the propofol's use for the pediatric sedation was abandoned shortly afterward. Similar presentations in adults started to be reported during the late 1990s, starting in 1996 with the case of a 30-year-old woman admitted with exacerbation of asthma who went on to receive sedation and invasive ventilation. The term Propofol infusion syndrome was first coined by Bray in 1998. The incidence of Propofol infusion syndrome is 1.1%. The clinical features may be classified into primary and secondary. Primary features characteristic and consistent with the Propofol infusion syndrome that can be the only presenting features, and the secondary features are those that occur in combination with the other features. The primary features include ECG changes characterized by covert pattern of ST elevation in leads V1 to V3. However, they can also include any form of ventricular or supraventricular tachycardia, bundle branch block, or bradycardia. Furthermore, severe new onset metabolic acidosis, a high anion gap metabolic acidosis, is often contributed to by renal dysfunction and a raised serum lactate. The third primary feature is rhabdomyolysis, which often become a causative factor in development of acute kidney injury. The secondary features are lipidemia, hyperkalemia, acute kidney injury, fever, cardiac dysfunction, deranged liver enzymes, and raised serum lactate. The major risk factors for its development are poor oxygen delivery, sepsis, serious cerebral injury, and large propofol doses. There is plenty of evidence to suggest a linear relationship between the cumulative dose of propofol and quantity and severity of features. Obesity, although there has been no clear relationship between the obesity and the development of propofol infusion syndrome, the dose of sedation should be calculated in obese patient based on the lean body weight rather than the actual body weight. Steroids contribute to development of critical illness myopathy, possibly by triggering enzymes that cause direct muscle damage. The rhabdomyolysis seen in the propofol infusion syndrome may occur as a result of the similar mechanism, and there is certainly a link between the steroid therapy and the development of propofol infusion syndrome. Catecholamines. There is a link between the use of vasopressor and the development of propofol infusion syndrome. It is thought that propofol clearance is increased by the raised level of endogenous catecholamines seen in the brain injured patients or in the patient with hyperdynamic circulation in context of sepsis or a systemic inflammatory response syndrome. This is also thought to occur with administration of higher doses of inotropic or the vasopressor infusion. The increased clearance may also reduces the therapeutic effect of propofol, thus there is increased need of propofol administration. Critical illness. The endocrine stress response to critical illness causes a surge in catecholamine and glucocorticoids, which are implicated as a risk factors for propofol infusion syndrome. These hormones modulate the activity of the lipase enzymes, promoting breakdown of the triglyceride into glycerol and the free fatty acid. Furthermore, in critical illness, there is a shift of the carbohydrate to lipid based substrate for the energy production, which also increases the free fatty acid. This is of importance as free fatty acids are key substrate for the part of pathophysiological mechanism of propofol infusion syndrome. It is possible for patient to develop a relative lipid overload associated with parenteral nutrition, propofol infusion, or both. This leads to an accumulation of the unused free fatty acid. There should be an adequate source of carbohydrate, perhaps in the form of the dextrose infusion, to balance this out and suppress the excessive lipolysis. The exact mechanism underlying Propofol infusion syndrome is not fully understood. We know that Propofol uncouples the oxidative phosphorylation and the energy production in the mitochondria, as well as inhibit electron transfer in the myocyte electron transport chain. This leads to disturbances in the ATP production, cellular hypoxia, and acidosis. Most of the existing evidence point to this as a most likely pathway for the etiology of Propofol infusion syndrome. Free fatty acid, which are an essential fuel for these myocytes during the stress, these free fatty acids cannot be used when oxidative phosphorylation is uncoupled. Thus, the free fatty acids can build up and act as a proarrhythmogenic substances contributing to cardiac dysfunctions. Propofol also antagonizes beta adrenergic receptors and calcium channel binding, further depresses the cardiac function and causing a degree of resistance to inotropic agents. It has also been suggested that the pathophysiology resembles certain mitochondrial diseases such as medium chain acyl coenzyme dehydrogenase deficiency, suggesting that a genetic predisposition to Propofol infusion syndrome may exist. Ultimately, the uncoupling effect on the respiratory chain and the resultant imbalance between the energy demand and utilization causes the accumulation of lactate and myocyte necrosis. This leads to metabolic acidosis, cardiac dysfunction, and rhabdomyolysis. The lack of clear definition and the inevitable presence of confounding organ dysfunction in critically ill patient means that there are no established guidelines for treatment of Propofol infusion syndrome. The condition is difficult to treat. The awareness of its existence, the risk factor for its development, along with high index of suspicion for signs in at-risk patient is critical. Some institutions monitor CK levels daily after 48 hours of Propofol infusion. Once diagnosed, the following are the priorities. Stop the further administration of Propofol. If needed, other sedatives should be used. Supportive therapy to treat the complications of Propofol infusion syndrome and elimination of Propofol from the body. Cardiovascular support in the form of inotropic agent and or vasopressor may be needed. Arrhythmias are treated in line with standard treatment algorithms. Catecholamine resistance cardiac shock has been reported, possibly as a consequence of calcium channel binding effect of propofol. The use of extracorporeal membrane support has been reported in such cases. Metabolic acidosis should be addressed as it may propagate arrhythmias, also reduces their effective treatment. It also potentially decreases the effect of vasoactive agents. This is done by ensuring an adequate minute ventilation, adequate intravascular volume, and the early consideration of continuous hemofiltration. Hemofiltration also has a role in the elimination of propofol from the body. Propofol is metabolized in the liver to water-soluble phenol derivatives, which are then excreted in the urine. Hemofiltration cannot eliminate the highly lipophilic propofol, but it can eliminate the water-soluble metabolites as well as help to manage the acidosis and hyperkalemia, which may be caused by cardiac dysfunction or rhabdomyolysis. There is limited evidence to suggest a role of bicarbonate other than as a temporary measure for hyperkalemia in the presence of metabolic acidosis. Adequate fluid therapy is needed to treat the myoglobinuria. It is known that the risk of Propofol infusion syndrome rises with the dose of Propofol in terms of both the infusion rate, that is more than equals to 4 mg per kg per hour, and the duration of the infusion, that is more than 48 hours. Although it makes sense to follow this recommendation, it is worth notice that cases of the Propofol infusion syndrome have been described only after a few hours of Propofol or at infusion rate much lower than that. Co-administration of other agents such as the opioid or the use of the additional or alternative agents when the sedation requirements are high is the way to control the dose of the administered propofol. If high doses are needed, close monitoring of the pH, lactate, and the creatinine kinase is imperable. Propofol should be avoided in the patient with proven or suspected mitochondrial disease because of the resemblance in the pathophysiology of two. Given the role of the free fatty acid in the Propofol infusion syndrome, it is also advisable to ensure a continuous carbohydrate supply to the patient receiving a Propofol infusion for sedation.